So I'm here to talk about our axitinib trial. I'll go quite fast. There's a huge group which I'll take at the end, but briefly, my mentor is Frank Warden in medical oncology. So quickly, metastatic head and neck cancer, we've heard this many times, has a vast number of molecular disruptions, including EGFR pathway, VEGF, and PDGFR. Axitinib is very interesting because it disrupts the entire VEGF pathway, not only VEGF1, as in the past bevacizumab has done. In addition to hitting all these targets, it is very tolerable. It can be taken PO, and it's been shown in many cancers to have a very low side effect profile. On a side note here, with responses to axitinib in several cancers, we've seen patterns of pseudoprogression. That is, it's anti-angiogenic. We actually see tumoral swelling and internal necrosis as it starts to have an effect. Due to this, this criteria has been termed the Choi criteria, which in several cancers actually more adequately predicts overall survival of patient-centered outcomes compared to RECIST. In our trial, it was funded by the NCCN. It was a single-arm phase 2 looking at 6-month PFS. Axitinib was titrated up full dose. 42 patients were enrolled. ECOG status was 0 to 2, could be any line of therapy. We had a post-hoc exploratory analysis based on Choi criteria, which I'll go into in just a moment. This patient population was heavily pretreated. I want to emphasize for one moment the overall survival in these patients. With first-line therapy using the extreme regimen, which we've heard of, it's 10.1 months newly diagnosed recurrent metastatic disease. These patients, 80% of them were second, third line or plus disease. In addition, I believe 90% of them were platinum refractory. 46% were HPV positive, and axitinib was continued for 3.5 cycles, although it's an asterisk we'll talk about in a moment, and there was a low side effect profile. Although there was 2 bleeding events, both did not result in cessation of the drug. There were simple nosebleed and a PEG tube bleed, and both cases restarted. The results were quite interesting. So this trial was initially stopped due to concern of PFS only being 30%. However, when we finally analyzed the results, the median overall survival for this group is actually 10.9 months. And that was quite impressive to us. In addition, looking at the response by RECIST criteria, although the PR was only 6.7%, when you factored in the stable disease, this actually came to 76.7%. Our waterfall plot, as we love so much, is shown in the center there, as our KM curve for survival is shown on the side. We built in a hypothesis going forward that maybe the reason that these patients were going off trial was truly because the tumoral swelling and necrosis, which in fact is what we were seeing. Talking to Frank Warden, talking to everyone else, these patients were having clinical benefit. They were feeling the best they had in their entire disease course, tolerating drug. It was fantastic. So we applied the Choi criteria. Although the scans were not optimized for such, they weren't available for all out of curiosity. And you can see here the Choi criteria does quite a nice job delineating out disease control rate and to really who had a response and who was really progressing. So in summary, axitinib merits further evaluation. Based on this data, NCCN has been contacted and they've awarded us funding to proceed with further studies in axitinib phase 2 and power it to median overall survival to see if this is in fact artifactual or true. The Choi criteria may be more useful in distinguishing response to TKI therapy, especially anti-angiogenic compared to RECIST, and should be evaluated in prospective trials. Going forth, I fully recognize there are many inherent problems with this, and that's one of the reasons we wanted to open up the expansion cohort. Issues, scans weren't optimized. They were read by RECIST 1.0, as well as PFS wasn't a good endpoint. That's why in the expansion cohort here, it's going to be powered to overall survival improvement, and also we're going to be using the Choi criteria to determine response as well as RECIST. At that point, thank you very much, and I'd like to acknowledge my entire team. Hope you're clapping for my team. They're the real workhorses here. And I cut some people out because I didn't have room. But Frank Warden's my mentor. Our facilities are here. Even though I'm a Michigan State fan, I have to do this. I have a huge otolaryngology, radiation oncology. I owe them a lot. Thank you.
Paul, this is very nice. You have good median survival. So what's the P16 distribution on your patients?
P16s did better. 46%, 46.7% were P16 positive. And I did not show that data, but there is a break off. P16s, I think their median overall survival was 13 months, whereas P16 negatives were 9.5, something around there.
I was just joking with Everett that I might be asking you the same question, and actually it did happen. But I do have another comment. I mean, obviously HPV tumors do better even in the metastatic setting, so I think that's important to figure out. But I do believe, you know, your data shows us yet again, and actually maybe even better than prior settings, that there clearly is a signal. It's a small signal, but it's a real signal for anti-angiogenic therapies in squamous or head and neck squamous cell tumors. The real challenge is how to develop this. Is there a possibility for a biomarker? I mean, those two patients that had a really good response, I think that's really meaningful, potentially. And the other thing that we've seen, and that's what I think was alluding to, we've done studies, this was with bevacizumab, where we had patients with long-term survival, truly long-term survival, where you wonder if the tumor ever would come back, good responses. And so there is something there, but how do you select these patients? And so I think it's really laudable to move forward with more data. I think it's really important to collect tissues to try to understand them. And I do believe that axitinib is actually a very good anti-angiogenic agent. So I think that's actually also favorable. So thank you for this work. I think it's important.
Thank you.
Just one more quick question. Because you look like you don't want to use RECIST anymore, do you want to consider continuum on therapy until clinical deterioration? Are you going to change your progression since you said it was so well tolerated?
So yes, the plan is to also include, as long as our IRB will let us, is get by continuing them on therapy as long as there's signs of clinical benefit. I feel that's justified and that there's very little currently available for these patients in standard of care. Hopefully immunotherapy becomes available here. But yeah, that's the plan.